Welcome back to Save Your Thyroid with Jennifer Holcomb, the show where we explore the latest advancements in thyroid nodule care and empower you with knowledge to make informed treatment decisions. Did you know that thyroid nodules affect as many as 70 to 80% of adults? And yet, for many people, the only options presented are watch and wait or surgery. If you've done your homework, you might already know about thermal ablation techniques like radiofrequency ablation, microwave ablation, or laser ablation, which use heat to shrink thyroid nodules without removing the thyroid gland. But what if there was a way to treat thyroid nodules without heat and without a scalpel? A way that targets the problem while preserving healthy thyroid tissue and protecting critical neck structures. Today, we're diving into an exciting new advancement, Nanosecond Pulsed Field Ablation, or nsPFA, a non-thermal, non-surgical technique that's changing the way we think about thyroid nodule care. Joining us again is Dr. Richard Harding, a general surgeon and expert in minimally invasive surgical solutions. Based in Phoenix, Arizona, Dr. Harding has been offering non-surgical treatments like RFA for over 5 years, and he's now one of the early adopters of nsPFA in the United States. Here's what we'll cover in today's episode. A quick refresher on radiofrequency ablation, how it works, and who it's for. An introduction to nsPFA, what it is, how it works, and why it matters. A side-by-side comparison, when to choose one technique over the other, real-life patient experiences with both procedures, and of course, we'll wrap up by answering your questions at the end. If you're curious about the future of thyroid nodule treatment or looking for alternatives to surgery, you're in the right place. Let's get into it. Welcome back, Dr. Harding.
Thank you. It's good to be here.
I'm so excited to have you back and to discuss some things that have become very exciting in this space in treating thyroid nodules, some things that are new and some things that are not as new, and kind of make some comparisons and contrasts. So can you start by giving us a quick refresher on radiofrequency ablation and how it works for treating thyroid nodules?
Sure. So with radiofrequency ablation, we are actually focusing on the nodule. We're placing the probe directly into the nodule to the very extremes of the nodule, just to the edges, so we can get every little aspect of the nodule. And then we'll turn on the device, which then heats up the very tip of the probe. And that tip of the probe will then heat up the adjacent tissue, and that adjacent tissue will then subsequently die because it's warmer than it can recover. So it doesn't burn it, it just heats it up where the tissue can't recover. And then the tissue subsequently dies, and then the tissue itself, which is initially the size of your whole nodule, will shrink over time, and then it shrinks with a process called gangrenous necrosis, which is your body taking care of dead tissue. And so it's different, and then you end up getting kind of a hard ball in there, which then shrinks over time.
And you've been doing this for over 5 years now.
5 years,
yeah. As a surgeon, I think it's always so fun to talk to surgeons about this because you do surgery, right? But you've adopted this non-surgical technique. So how has this really changed your practice where you're not always doing surgery for patients' thyroid nodules?
So people love this, but they also like surgery too. So it's for patients who are really motivated to avoid surgery, for one thing, there's nothing wrong with that. And then also patients who have a benign nodule, so something that we know isn't going to hurt by leaving it in, and then something that is accessible based on the location of where it is in the neck. And so if it has those three criteria, then you can go in and treat it and leave it there, and then just follow it with ultrasound. But it does require a fair amount of follow-up over time, because people want to know how exactly that nodule's behaving after the treatment. All these ultrasound guided treatments will require some degree of long-term surveillance.
Do you have a sense of how many patients you've seen over the last 5 years for this procedure for RFA?
For RFA, so there's a lot that come that really truly aren't candidates.
Yeah.
So we've seen like 500 patients, but I've treated about 150 for this over time. So I would not consider myself the highest of volumes of providers, but I've still seen a vast array of sizes and different types of nodules and that sort of thing.
Yeah, and we actually filmed some procedures in your clinic a few years ago. So anyone who's watching this who wants to go back and see that episode, check the description below for the link to that video. Now let's get into nsPFA. This is Nanosecond Pulsed Field Ablation. It's a little bit of a trickier acronym to remember, but it's so different from RFA. Tell us what's different about the energy that's delivered and the tissue interaction.
Right. So radiofrequency ablation uses high frequency alternating current, and that is just very focused at the end of that tip of the needle. Whereas this particular device is direct current and it releases pulses, nanosecond pulses of energy into the tissue, which creates a halo of energy into that tissue. And that those pulses of energy will change the membrane potential of both the cells and also the membrane or the organelles within the cell, causing an influx of ions. Those influx of ions cause what's just a cellular deregulation or just abnormal intercell processes. So it won't kill it, it won't burn it, it just causes cell processes to become abnormal. And then the cell itself will then undergo its own process of degeneration, which is believed to be a cell regulated process in which the cell now gets absorbed in a natural way. So instead of having dead tissue there, you have live tissue that absorbs the damaged tissue. And so you just basically get a softer area of tissue with no scar at all. So what's different is that you have no scar and you also have no change in the vascularity of the lesion.
When you say no scar, you mean internally inside of the thyroid gland?
Correct. So the nodule itself gets smaller. On ultrasound, it looks like the same exact nodule. So you don't have an area that becomes suspicious.
Right. So let's talk about that for a minute. On ultrasound, after you have treated a thyroid nodule with radiofrequency ablation, it does undergo some changes in the visible characteristics. So since you just described how that looks on a nodule that's been treated with nsPFA, talk about RFA nodules.
So the RFA nodule becomes what's called hypoechoic. It also has heterogeneous changes that are related to how the body wants to absorb the nodule. The edges of the nodule become irregular. Sometimes you'll have a viable margin. Other times you'll get the whole nodule with your treatment, and you'll just see a big black area that we call, is when it's black, it's hypoechoic. Hypoechoic lesions, however, look suspicious based on our initial opinion of thyroid nodules. So when you have a thyroid nodule that's hypoechoic, that's usually a warning sign that it's cancer. Well, that's why we want to biopsy it several times ahead of time to make sure it's not cancer, because we know it's going to change after RFA. And so we just, you have to become familiar with what RFA changes look like on ultrasound. And that's what's really important about undergoing one of these ablations, so that you understand that the tissue is going to change and that the doctors that you seek out should be ones that are familiar with the changes associated with radiofrequency ablation. With PFA or nanosecond PFA, the nodule looks pretty much identical. It's just much smaller and much more compact. So, I mean, it's different. It's neat. So,
sure that if a patient were to say they traveled to see you from somewhere out of state and then had an ultrasound follow-up with someone locally who's never seen a nodule that's been treated this way, they're probably less likely to freak out than they would if they saw a nodule that was ablated with RFA or some other heat modality, because those nodules do look suspicious. It doesn't mean they are suspicious.
right.
It just means they look different because they've been burned. So I would love to kind of get some, I would venture to say not inexperienced, but maybe technicians in the ultrasound world who haven't experienced these ablation techniques and kind of see what their reactions would be between RFA nodules and nsPFA nodules. So these electrical pulses that are happening during the nsPFA procedure, how is that working exactly while not disturbing the delicate structures that are in the neck? You've already explained the process of how it's destroying the nodule, but how is it not harming the adjacent structures like the trachea and the esophagus and all of the veins and arteries that are nearby?
So the pulses of energy are basically pulses that have current in them, not current like in alternating current, but they have a voltage which changes the membranes, but doesn't change fixed structures like the collagen or the actual, well, collagen is in both the trachea and in blood vessels. But a lot of blood vessels have cells that don't have a lot of cytoplasm. So a lot of the cellular processes are not disrupted. And the same thing with nerves. The cytoplasm in the nerve is not where the actual nerve is. It's far away from the nerve. And so you can use that energy right next to the main axon of the nerve without disrupting the nerve. And so as a result, it's safe to apply almost directly adjacent to normal collagen and blood vessels and that sort of thing. And you're not going to disrupt those.
Wow. So let's talk about for a moment with patients who have thyroid nodules that are in the danger triangle. And for those watching who aren't familiar with the danger triangle, that's an area in the thyroid where it is very close to the recurrent laryngeal nerve. This nerve controls the voice and the ability to swallow. And why would you not want to treat a nodule in that area with radiofrequency ablation? And is it possible to treat nodules with nsPFA in that area?
So you can really get right down to it with nsPFA. So if when you're doing a big nodule, and especially the deep ones, if you apply your energy deep down inside there, you're going to be applying not only the energy, but the area is going to heat up, and that heat's going to transmit down to that nerve, and then you're going to have hoarseness, and you don't know if that hoarseness develops, if it's going to be something that person's going to recover from. And so as a result, there's certain rescue methods that we have to cool the tissue down. We'll inject cold water down underneath it, and then we wait and see. But sometimes it just happens, and you just have to wait. And sometimes it takes 2-3 months for patients to get their voice back. And so, any effort that we can do to avoid that, we do. But that has the net effect of leaving tissue in that area, and that tissue can become larger in the future. And so basically you're just doing a subpar ablation. And it's recognized that we do that. So it's just, we discussed it in advance. With nanopulse ablation, you can put the probe pretty close to it, and it's only 8 seconds of the energy at each time that we ablate it. And so far, I haven't had anyone get hoarse from that.
So let's talk about treatment duration. So when you're treating a patient with nanosecond pulse field ablation, you just mentioned 8 seconds. So surely the entire treatment's not 8 seconds, right? Like
Right.
how long is the entire treatment, and what does it look like in terms of zones of treatment?
So you have to think about each incremental area is supposed to be about a milliliter of area.
Okay.
And so if someone has a 20 ml nodule, technically, 20 treatments of the pulse ablation should be sufficient. I've actually doubled that. Actually, in some cases, I've tripled or even quadrupled it, just because I want to make sure that this works. And the areas don't change much. So when you're actually doing the treatment and you're watching an ultrasound, you're not seeing a lot of change. And so as a result, and when I do it, I overlap those treatment areas so as to not leave tissue that's not treated. And then, so when you think about it, 20 seconds times, 20 treatments times 8 seconds is not a lot of time, but there's also time in between where you're moving the probe, you're making sure that your probe is in the exact spot you want it to be. And so it still takes a lot of time. The treatment with pulse ablation tends to cause people to cough. And so when we're treating it, they're coughing. You have to give them a little break to let the coughing go away and that sort of thing. And so there's some time that you have to give the patient just to kind of recover. There's some twitching of the arm. You get some of this, which is different. No one's ever experienced that before, so it's just a different experience. And when you ask them afterwards, does it hurt? They said, nope, doesn't hurt. It's just different.
Right. Right. So do you kind of prepare them in advance for that sensation?
Yeah. I actually have a TENS unit that physical therapists use for the back and stuff, and I'll usually put it on their arm, and we try that out just to see, and I let them turn it all the way up and stuff just to see how they make it feel. And then when we try it, when we do the procedure, they're actually quite comfortable as a result of that experience, ahead of time. Not everybody wants it. Not everybody volunteers for that, but I still have that as an option.
So that's a similar sensation, you would say, between what they're experiencing during the procedure?
There's different settings on the TENS, so I had to try to guess which one is the closest.
Mm-hmm.
The ones that have the rapid pulse. And then during the procedure, there's ways that we have to decrease the amount that people feel, which is by injecting water all the way around, which is D5W, all the way around the thyroid, to kind of isolate that energy directly in the thyroid itself.
And do you numb them also with lidocaine as you would with RFA?
I do. And I actually have a way that I do a cervical plexus block. And so before the patient even gets the lidocaine block, I can block the nerve back here, and this nerve goes across the front of the neck. And so I'll put about 5 cc's right where those nerves are. And then while we're prepping and looking around, that'll start to work. And then I do the regular thyroid blocks. So as a result, people are usually quite comfortable.
Yeah, I remember when you did that, when I filmed some of those procedures at your clinic, and I thought that was really cool because I've never heard a single other doctor mention that they do that. And is that something that you learned how to do because of your surgical background?
Right. And so that's something that's actually started by, well, believe it or not, 100 years ago by thyroid surgeons. Thyroid surgeons used to be doing thyroid surgery under local anesthesia because anesthesia, the full general anesthesia was much more dangerous for some people. So they do the whole operation under local. So you read what they did back, 100 years ago, and you realize that it's similar to what's described that when we do our parathyroid blocks. So when we're doing parathyroid surgery, you do a block behind the muscle right here, and then it tends to numb up those muscles, and then you just add a little extra right there, and you can do the whole operation under local anesthesia.
Wow.
And so amazing. Rather than letting people get uncomfortable, I try to just preempt that ahead of time.
Oh, I'm sure patients appreciate that. What about their recovery time after the procedure? Are they going to have any soreness or need to have any downtime afterwards?
Yeah, I've had various responses the next day. Some people say they have no pain at all. I've actually done some of these nodules on patients who had radiofrequency ablation, and then brought them back and did a pulse ablation on them. And one patient said it was like way different, way better. The other person said she had more pain with the nanosecond pulse. And so it's different. They also get pain in the back of the neck from being there in that position while we're doing everything. And that's with both RFA and nanopulse, where that back of the neck is very stiff just from us doing the procedure. And so we try to give them muscle relaxants now and try to give them something like Xanax or Ativan ahead of time.
Yes, that in my experiences with RFA, Ativan during the procedure helps so much to just relax you and calm your nerves. And I did have a little bit of that same sensation you were describing with the stiff and tense shoulder and neck muscles. And same for me. I had some Flexeril afterwards, and it takes a day or so for that to kind of calm down. Let's talk about risks and side effects for nsPFA. Have you seen any of those?
So initially, the company had a large probe, and that large probe was a lot bigger than what we were familiar with radiofrequency ablation, but now they have a smaller probe, an 18-gauge probe. So it's basically the same from the standpoint of using the probe and then advancing through the tissue. My initial concerns was that we were not going to get hemostasis from the experiment. In other words, when you put the probe in, you can cause bleeding on the way out. I haven't seen that. So I haven't seen problems with bleeding because the energy actually decreases the blood flow within the thyroid nodule itself. There's something about doing that procedure and the blood flow goes down. So when we do our follow-up ultrasound at the end of the procedure, you see the nodule does not have as much blood flow as it had beforehand. So as a result, I have not seen a hematoma. You get a mark at the skin for both procedures, and that's pretty much similar. Other than the changes that I see during the surgery, I haven't seen a lot afterwards that's any different. So it seems to be about the same. But I will say I'm using this on larger nodules. So I'm not doing little baby nodules like with thyroid RFA. I'm doing toxic nodules that are small and stuff. And those patients obviously just skip on out of the office and they're doing fine. Whereas I'm doing bigger nodules because it takes, less time with pulse ablation than it does with RFA to do the big nodules.
That was going to be my next question, is what is the ideal nodule for nsPFA procedures?
Right. So when we think about how the nodules change after the procedure, so with pulse ablation, you're not killing the nodule. You're basically stunning it in a way that induces apoptosis. So you're inducing a natural organized cell death. And so whereas the other procedure, you are basically causing gangrenous necrosis where the tissue is dead. So with radiofrequency ablation, I've seen patients come back with a kind of a golf ball knot on the side of their neck, and it lasts for months. I mean, it lasts for sometimes a year or so, and it takes a long time for some of these to go away. Not everybody shrinks 80% in 7 months, 6 months. Some people, it shrinks 40%, and then it takes another 2 years for it to shrink down a lot further. I mean, it just depends based on each person. But the really dense lesions, which, for instance, someone with Hashimoto's thyroiditis, they're going to have a very dense thyroid. And if they have a dense thyroid and you heat it up and you kill that tissue with radiofrequency ablation, that nodule and that thyroid is going to stay hard almost forever, and no matter what. And I've seen patients who've had treatment in the past by other doctors and they want a second treatment. And I have to explain to them, this is before pulse ablation, I had to explain to them that this is not what you want because it's just going to stay hard. Your symptoms are not going to get better. And so with pulse ablation, let's say in patients with a really solid, hard nodule, those nodules all get much softer. And they shrink, and so they don't shrink. Like, for instance, they don't go like this, like a radiofrequency ablation nodule will go from this to this. With pulse ablation, it goes like that. So but it gets more narrow. So the thyroid gets much more pliable and soft. And so the patients, notice that they have improvement symptoms within a month, within a couple of weeks, actually. And then they can't really they feel there's fullness there, but the thyroid's softer. And so it feels more like a normal gland.
Wow.
And which that includes patients with Hashimoto's thyroiditis too. With the Hashimoto's thyroiditis, patients get a lot softer.
So the nodule just kind of collapses inward instead of shrinking volumetrically consistently. It sort of collapses, is what you're explaining?
It's just smaller, but it just seems more narrow. Yeah.
Wow,
but it doesn't have that concentric shrinking that you get with RFA, where you get that scar around it, for instance.
Wow.
So it's different, and so it's just that's why one seems better for some people, whereas others to me are better for others, and that's why I have to basically look at the patients first and see the density on ultrasound before I can choose as to which one's better.
I've heard a lot of doctors over the years tell me that spongiform nodules are great to treat with RFA because they have such a light texture and, they have those tiny little pockets of fluid in there that prevent it from being very dense, like what you were just describing with the Hashimoto's nodules.
They shrink very well with radiofrequency ablation. Yep, they shrink a lot. With this, I don't have enough experience with spongiform nodules to know whether or not we're going to see that same result with those types of nodules.
Okay.
So it hasn't been around long enough.
When did this procedure come out?
So I did it May of last year. And then there was a time period where they were changing catheters and they had to get a permission for new catheters. And as a result, there's about a 4-month period of time that we weren't using it. And then once the smaller catheter's out, we started up again. So it's been almost a year, and we definitely have patients that are a bunch of patients that are 6 months out.
Well, let's talk about the patient feedback. What are the patients saying?
So when I say it varies, they're all relieved of their symptoms in terms of pain and pressure. And so when I call them, they all come back and we fill out a survey, and they're all very happy about the symptom relief, which is great. And then you ask them, do you feel anything in their neck? And they say, no, I can feel that there's fullness there, but I don't feel the actual nodule, right? So it's different because some people come back after RFA and they say, it's smaller, but I always have this right here. I can just feel that thing moving all the time. So that sensation is different, and so they get the symptomatic improvement. That's I would say that they're equivalent.
And what about the cosmesis?
Looks good. I've treated one patient. She had 3 nodules across the front, and she did great. She slept through the whole thing. Her volume initially was like 40, and now it's maybe like 10. The whole nodule shrank a lot, and she had 3 individuals, and you can still see a little bit in the front because the ones in front, even with RFA, always seem to kind of stay there a little bit. But overall, the fullness in her neck is much improved. And so it always depends on that patient too, where the nodule is as to how much you see.
Any other patient stories that really stood out to you that had a really dramatic experience with their change in size, change in symptoms that you would like to share?
So they some people were just really excited about it, and in fact they were all excited to tell you all about it. And so that's fun because they've noticed complete relief of their symptoms from this, which is obviously, as a surgeon, that's what I want. If they have any symptoms at all, I'm not happy about it. So I would say half of them are completely without symptoms. There's some that still notice a little bit and they're still in transition. So we're waiting for those patients to kind of sort themselves out. But again, the nodules that I'm treating tend to be, up to 40 or 50 mLs in size. I'm treating really big nodules. I'm not
Mm-hmm.
treating the 10 ml nodules. Like a lot of people are treating these little small nodules, and it doesn't matter what you do to those are going to get better. But I tend to get a lot bigger ones in my office. So as a result, if someone has a 20 ml nodule that's there still, I mean, that's still a pretty big nodule. So you have to be realistic about what patients that, what results that you get based upon that.
So just for patients who aren't as familiar with the volume, using a volume designation, can you give a sense of how big a nodule is that would be about 20 milliliters?
So 20 mLs will be about 4 by 3 by 2 centimeters, about that, which is still pretty big, right?
Mm-hmm.
That's a big one. Whereas a 40
Yeah.
ml nodule is going to be like 5 by 4 by 3. I mean, so it's volumetrically a big difference.
Totally.
So a shot glass, when you think of a shot glass, you don't think of anything that's all that big, but a 20 ml nodule is something that you're just going to see from across the room.
It makes a difference because you're talking about a really small area. If someone had a tennis ball in their neck, that would be like quite substantial.
Right. Right. That would be close to 80 ml nodule, right?
Yeah.
That would be almost 100. Yeah.
Wow.
So, but
Wow.
a golf ball is going to be like 30 ml. So, I mean, it's so 20 is still big.
Those are really helpful comparisons. So thank you for sharing that. Hey, just a quick break to share something I'm really excited about. My brand new website, saveyourthyroidwithjen.com. You can head there to subscribe to my mailing list and stay in the loop about new podcast episodes, videos, and updates in the world of thyroid nodule care. And I'm now offering something new, one-on-one patient navigation services. If you're feeling overwhelmed or unsure about your treatment options, I'm here to help. As a patient who's been through this myself and spent years learning from some of the world's leading experts in thyroid nodule treatment, I can help you make sense of your choices and feel more confident in your next steps. You can learn more about patient navigation and everything else I'm working on at saveyourthyroidwithjen.com. Now back to the conversation. Let's talk about how you're explaining the difference between these two procedures to your patients at their consults.
I'll explain to them, this is what will happen if I treat you with this energy, and this will happen if I treat you with this other energy. And then based upon the ultrasound, I'll have to describe again the danger triangle and stuff like that. Mm-hmm. Some patients are very fortunate that their thyroid nodules are nowhere near the danger triangle, and you can really just go and ablate it. Some patients don't like the idea of the potential risk. And I think that the potential risk for radiofrequency ablation in terms of a change in their voice the potential risk is a lot higher than it is with PFA. Some people like the idea of the fact that the tissue undergoes the apoptosis and just sort of disappears without changing the appearance of the nodule. So we go over that first, about what they would expect to change. And then we talk about, the actual treatment itself. To be honest, I'm pretty good at making people comfortable for the procedures. Like radiofrequency ablation, I'm pretty good at making that so that they don't feel it and they're not too uncomfortable. nsPFA is different, so we have to go through a lot more discussion about what they will expect ahead of time so that they're comfortable. We're going to try taking it to the operating room and giving them a little bit of Diprivan or a little bit of IV anesthesia ahead of time. That way, then they won't remember anything, and then that would be perfect. But that hasn't started yet, so we're going to be doing that pretty soon.
Interesting. Have you had any patients who expressed after they had their procedure that they wished that they had that, or have they all been pretty much okay with it?
Patients are tough. I think the ones that we see that expect it, they say, I expected some discomfort. I mean, this is just something that I expected. Like when you go to the dentist, you expect some level of discomfort. But, it's certainly nothing that we want them to experience. So I want to make sure that they have the best experience with it. With an anesthetic, actually, the treatment can go a lot faster than it is in the office. So you can do the treatment in less than a half hour or even less than 15 minutes in some people with an IV anesthesia. Whereas in the office, sometimes, depending on how much time if patients need between each ablation session or each 8-second session, some people, because they either cough or they'll have twitching, they just want you to catch their breath, for instance.
Mm-hmm.
That's the one thing that slows us down a little bit. So some patients are very reluctant to try Ativan and to try the Flexeril and stuff. They're a little nervous about that. And so as a result, they have some side effects that that it just takes a little extra time.
Would you use that IV sedation that you were just describing?
Right?
That prevents them from experiencing that cough sensation?
I have not done it yet. So
Or is that what the intention is?
right. So they don't
Okay.
have the coughing and they don't move as much. And then you can just go focus on just getting that energy, applied and just get it over with. Yeah.
You said that you've treated some patients with nsPFA who've already undergone an RFA
Hmm.
procedure.
Yep.
What do you think, would there ever be a situation where it would make sense to combine the two modalities intentionally?
I didn't really think of that actually. So the patients that I treated, they had 80 ml nodules. So when you think about how big an 80, you talked about the tennis ball, right? An
Yeah.
80 ml nodule was really big, and the reason why they have 80 milliliter nodules is because they have a thyroid disease commonly referred to as nodular hyperplasia, and those thyroid nodules shrank initially a lot, and then they grew back, and they
Mm,
grew back around the areas that was treated. And
yeah.
so we were trying to find another way to treat them which would work, and also, and these patients are valuable resources because they give us information about the treatment and how it responds to it and that sort of thing. And so we asked them ahead of time if they would be willing to give us their opinion about all these things so we can compare the two procedures, for instance. But that's an interesting concept because I think when you kill something with radiofrequency ablation, there's no sense in inducing apoptosis process, if that makes any sense. So if you're going to ablate it with thermal energy, just ablate it with thermal energy, because I just don't see how that the apoptosis process would benefit.
Mhm,
Unless you're just going to treat an area specifically around the nerve, just to kind of get,
mhm,
to make that. But I mean, each procedure is kind of as its own expense.
mhm,
So from a practical standpoint, I don't see that those would be performed at the same time
mhm,
because they are expensive procedures independent of each other. So then
mhm.
you would just be doubling the cost of the procedure. So
Yeah, I didn't expect you to say that there was a practical way that that made any sense. I was just curious. And I think it's interesting that you've treated some patients who did have a not so great reduction in their nodule after RFA. We do have a small number of patients in the Save Your Thyroid community who have, unfortunately, not had the greatest results after one or two sessions of RFA. And
mhm.
some of them have gone on to have microwave ablation. And, that nodular hyperplasia that you mentioned a moment ago, how is it determined that that is what is causing this nodule to continue to regrow?
When you do an ultrasound, you can actually see that they have that process throughout the whole gland. You can see it on both sides. They have very glandular, fluffy tissue on ultrasound, and they'll have one nodule, usually that's the biggest, that just brings them in as the one that's biggest. But you can see that they have that whole process up and down the entire thyroid. Usually the inferior parts are the most involved. And so what happens is you treat that lowest, biggest one, and then it shrinks for a while, but then it starts getting bigger elsewhere in the same patient. So you can technically, you're not treating the same tissue because that tissue has died, but you're treating the tissue that's grown around it. But yeah, those patients, they have to decide what they're going to do. They can either have the whole thyroid out, or they can just go through several treatments.
Mm-hmm.
So in China, where they do multiple treatments often, they're treating 20 ml nodules with 2 sessions of radiofrequency ablation and are reporting on that. Whereas we're treating 40 and 80 ml nodules. So
Mm-hmm.
it's not unreasonable that these patients should expect to have a second treatment given the size of those nodules. Yeah.
Yeah, that was my experience. Mine was somewhere between 65 and 75 mLs, and I had to have two sessions of RFA, partly because my nodule was slightly below the clavicle, and so
Right.
it was not visible on ultrasound. So we did a two-step approach. He treated the top part, and then 9 months later, he treated the rest of it after it moved out of the way. And for patients who have this nsPFA procedure, is it possible that that same approach could apply in those types of nodules that are partially behind the clavicle? Because we do see a lot of patients that have that problem.
True. And so the way that the RFA shrinks the tissue is kind of a concentric.
Hmm.
Whereas with nsPFA, it's elongates the nodule, so they may not pull up as much,
Okay.
but at least from the standpoint of probe placement, you can probably place your probe a little bit more deeper than you'd normally place, or even next to, even close to the esophagus, for instance, where you wouldn't dare do it with a radiofrequency ablation. So you could probably ablate a larger nodule that would still affect the symptom relief, for instance. But you're not going to get, I don't think you're going to get that to pull up like you would the iceberg effect with radiofrequency ablation.
Okay, I like the iceberg effect name. I've not heard anyone call it that before.
Yeah, you just treat the top and it shrinks up and you bring it and treat it again.
Oh, that's really cool. I'm going to have to use that from now on. Okay, well, let's talk about nsPFA. How do you believe it's going to fit into mainstream thyroid care in the next 5 to 10 years? Because RFA's already become way more common in the last 5 years. We started off in 2019 with 2 physicians in the United States. Well, actually, two centers in the United States offering RFA. Now, across the 7 different treatment options that are available that are non-surgical in the United States, we have 180 different treatment centers. So a lot of progress, still not available in every city or state, major city or in every state, but it's changing thyroid care. It still has a ways to go. So how do you see this fitting into mainstream thyroid care?
So that's a good question, and I don't know if I have the exact answer for you, because we know that radiofrequency ablation and even microwave has a lot longer track record in terms of what to expect. And so when you start off your radiofrequency ablation center, you know that the results that you can get, and it's been proven around the world that you can get the same exact results as not exactly, but just as skilled guys around the world. I mean, you're going to get at least a 40% ablation within the first 3 months. You're going to get 50% within 6 months, even if you do a bad job. Whereas with this, you can treat it a lot. You can treat the nodule a lot more. It's safer to do, to be honest with you. For the PFA is safer because it's really hard to damage the tissue. It's just a matter of finding the exact way to treat it that makes it efficient. And some people, I would not say that it's ideal for endocrinologists yet, but there are some endocrinologists doing it that are very familiar with it. But it's not the perfect one to train on. Even though it's safer, it's not the best treatment to train on because the tissue doesn't change as much. So in other words, when you're doing the radiofrequency ablation, you can see the tissue change and you can work from one area to one area to one area. With this, there's concentric areas that you treat, but you have to be very familiar with how you're moving your probe into those other areas so you can get a complete treatment and not miss any. And so because the tissue doesn't change as much. So it's going to take a little bit more experience for the people using PFA.
What about repeat treatments? Is that something that could be done?
Well, that's what excites me, is because you can retreat a PFA treatment and it'll continue to shrink even further. Whereas when you put a RFA catheter into an area that's already dead or necrotic, it's not going to shrink anymore. And so there's almost no point in treating an area that's hard and thick and rubbery with another treatment. And so you can expedite the shrinking of a nodule with PFA by treating it second time up front. But again, that increases the cost of the procedure, but it works and it's easy to do. And the patients, since they're familiar with it, are very eager to go ahead and do it. So we've treated 2 people twice, and both times it expedited the reduction in size of it. And they were both bigger than 20 mLs in size.
You mentioned about cost, about these being expensive procedures. What do you think is going to be the biggest challenge for these technologies to be accessible? Is it, you believe, insurance coverage or physician training or just general awareness could be barriers?
So we don't know what insurance companies are going to pay for this procedure. For instance, the probes, I don't know if they're manufactured in the United States or they're manufactured elsewhere. With the new tariffs, we don't know what the probe costs are going to be for RFA or microwave. They're going to be very high. And so suddenly the cost of RFA is going to be prohibitive for the provider offering the procedure because the cost of the equipment will take away any profit margin at all. So we don't know. And this procedure, the pulse ablation, is out of California. So it's an American company, but I don't know if all their supplies are American. I don't know what type of tariffs they have on those supplies. So that is a factor I think is going to affect everybody with this form of treatment, because most of this technology is out of Korea and China.
It was interesting you mentioned that training in RFA, you have this ability to kind of see where you've treated already. So would you
Right.
suggest that a physician start with a different modality like RFA and then graduate to this?
Yeah.
Or could,
I think so. I think
yeah,
because I think that there's a lot of aspects of RFA which are easier to pick up initially, and it's not just probe placement, but it's also probe movement through the tissue and also the anesthetic techniques.
mhm.
So someone who has done a million biopsies would not have a lot of difficulty in the hydrodissection part of it. But the hydrodissection part of it is the part that we do before we even start the treatment with pulse ablation. So if you're doing a pulse ablation, you have to put fluid all around it to isolate that energy in the thyroid. And that's actually sometimes the hardest part about the procedure is getting that fluid between the trachea and the thyroid, and then getting the fluid behind the thyroid to buttress behind the nerve and the muscles behind there. And if you do it properly, the patients are very, very comfortable.
And I imagine that fluid probably is why they have that fullness directly after the procedure, but over
Yeah.
time that will dissipate and then they'll probably feel all of that just completely go away.
And so my pulse ablation, the success I've had with the pulse ablation has led me to start using a lot more hydrodissection for my radiofrequency
Really?
ablations. And so I'm adding a lot more fluid all around those patients too. And then we can really zap the thyroid without them having any discomfort at all.
Wow.
And so
That's
that's
great.
always very helpful.
So currently I know you're using nsPFA for benign nodules, confirmed
Correct.
benign on biopsy. Do you think that eventually this could be used to treat malignant lesions? And I think that this is important because a lot of times we see patients with, a thyroid cancer that's really small and that would qualify for RFA or another thermal ablation treatment, except it's near the danger triangle. So
Well,
what are your thoughts on that?
that's an interesting point. They certainly, the company intends to get authorization to treat cancers, and I think in those certain circumstances that would be a good place for it. I don't know, the idea is that this energy affects all the cells, and you get all the cells affected by the apoptosis effect, and then the cells just die and get absorbed. I don't know if you get 100% kill on those nodules. So that's the issue is that that's my reluctance to
Mhm.
proceed. I am not doing cancers yet, and it's not because I don't want to do cancers. I just haven't found one in a good spot. And so with
Yeah.
RFA, that needs to be in a really ideal spot in order to treat it appropriately.
Real quick, explain to patients that are looking into RFA for a thyroid cancer, what are the requirements for those nodules?
So for cancer, it has to be now. So in China, you can't look at China because China is doing lesions that are between 1 and 2 centimeters in size. They're doing metastatic lymph nodes and that sort of thing. So, but in the United States, we recommend less than a centimeter in size. It has to be a good 2 millimeters away from the trachea. You have to have a good margin away from the muscles. It has to be usually right in the middle of the thyroid. And it's really, most lesions are not in that location. Most lesions are on the periphery somewhere or deep close to the nerve or too close to the trachea. So they disqualify themselves just by virtue of where they are. And so you have to have a biopsy, of course. And then, of course, they can't have lymph nodes present in the neck. So if you have any signs of advanced disease, the other side's got to look perfect as well. So if you're doing an ultrasound and you see lesions on the other side, then there's no point in treating this one with any type of treatment, for instance. So you have to kind of make sure that it's really an isolated nodule. But some people have multifocal papillary thyroid cancer and they're treating that with RFA. But they have to be in the right spot.
Okay, well, we're about to get into our listener questions, but first, I'd just like to ask you, what is one piece of advice that you would offer to patients diagnosed with a thyroid nodule today?
So a lot of people are very anxious about thyroid nodules. It really creates a lot of anxiety, and in fact, it's kind of funny because I have this philosophical discussion now that I didn't have years ago. It's the advent of high frequency ultrasound or high definition ultrasound has identified nodules and these problems in the neck that people never knew they had in the past.
Right.
And so as a result, there is this tremendous increase in diagnosis of thyroid cancer because of this high definition or high resolution ultrasound. And so we're seeing a lot more thyroidectomies, we're seeing a lot more biopsies and that stuff, the stuff that never happened in the past. And so it became known as the epidemic, or the thyroid cancer epidemic, that it was just the incidence of cancer is exploding, and it was really all about basically identifying it very early in its process. A lot of these people would not even know that they had it.
Right.
But a thyroid nodule, if it's big enough, they should biopsy it. If it's symptomatic, we should treat it.
Mm-hmm.
And basically, once you biopsy it, and all the biopsying technologies are so much better than they used to be to help define if it's benign or cancer. And really, the only really, when I say big ones, lesions over a centimeter should be checked, over 2 centimeters if they look relatively benign. And all the guidelines for the ATA are changing to be less prescriptive in terms of biopsying everything. So there's going to be less surgery, less biopsies, less follow-up, which is good.
Right.
But if you have a symptomatic thyroid nodule, though, the chances of it becoming asymptomatic is pretty much zero. So if the nodule's big and it's causing symptoms, then those are the ones that we want to treat.
What about clinicians? What would you say to any clinicians who are considering adopting a thermal or non-thermal technique like nsPFA?
So I think it depends on your volume, because you're right now, the way that this is billed, if you're going to bill it through insurance, it's going to take you 30 procedures to break even. And that's just with because you have to pay for your equipment. So
Right.
You'll do a whole year of procedures without receiving a dime. So it's not that I want to be discouraging to people who want to try it, but you have to look at the cost of the actual equipment itself and actually the cost of performing the procedure. So if you're billing at a network, you can probably make a little bit more money with that, but billing through the way that it's been proposed by AMA makes it incredibly unprofitable to do. So there's going to be a lot less people trying to learn it. Mm-hmm. To do it in the office, they basically want you to take about 3 times more than a biopsy would pay, and it takes you about 100 times more time to do. So I have to be realistic when I tell people who want to learn it, because there's a significant cost in embarking upon it, and you have to take time out to learn it. So I think that people who are motivated in taking thyroid cancer patients should go out and learn it, because they're going to be doing that for their career. But they have to be realistic about the return on their investment, because it's a significant cost.
I think that for the physicians who are considering doing this and really want to hone in on thyroid cancer, I want to say to those physicians who are watching that there are a tremendous number of patients in the US who are interested in this treatment option, and a lot of them are going overseas to be able to access it. And so I think that just letting physicians know that the demand is there is helpful. And I don't know, like we were talking about just a moment ago with reimbursement with the code. I did an episode on this with Dr. John Russell last fall, where we talked about the new CPT code for RFA. I'm hoping that will maybe be adjusted at some point down the road, and that we'll see a better reimbursement rate for physicians, because like you said, it's very difficult to keep your business open if you're not making money. And it's not a matter of, wanting to have the expensive house and car and the lifestyle. It's a matter of needing to keep your business open, paying your bills and paying your staff. It's just like any other business. So that's really important, I think, for a lot of patients to understand.
The AMA did not, when they set the fees and stuff, they did not set any changes in the fees if there's increase in cost to the providers, right? So those provider costs, which will affect the hospital as well as people who are doing it in their office. And we don't know what those are going to be yet.
Well, now let's move on to listener questions. And some of these we've kind of already covered. Okay, this patient asks, would you recommend nsPFA for a toxic nodule that did not respond to RFA treatment?
So that's an interesting question, because my 2 toxic nodules, which I had, were very big. And so historically, that would mean that they ought to be treated twice no matter what. And so with either RFA. And so we treated ours twice with PFA, and have seen their thyroid function improve and their nodules shrink even further. So we're at this time optimistic that it should continue to improve for these patients, but we're not exactly confident enough, at least from my standpoint, that that's going to be the way to go for big toxic nodules. And some other doctors have had a lot of success with smaller ones, which is what we're seeing with RFA. So for me, I'm going to keep doing the smaller ones using RFA. The big ones, they may just need to be another treatment.
Toxic nodules across the board, the bigger they are, the harder they are to treat.
Yep.
And I know one patient in particular who had a sizable toxic nodule, and she's undergone 3 RFAs.
Wow.
And I don't know if the last one, it's been pretty recently, so I don't know if she's gotten levels checked yet, but I know that she was still having to take methimazole, unfortunately, even after 2 procedures. So, but she's very, very motivated to keep her thyroid gland. And so that's what we see in the community is patients are just very motivated to keep their gland intact. If papillary thyroid cancer were treatable with this, which it's not at this time, would it be something that could be used if there was an affected lymph node? And I know this is speculation, so I'm just curious what you think.
So anytime you think there's lymph nodes, if you're looking at an ultrasound and you see one lymph node, the chance is that they've got a lot of lymph nodes and you just don't see it on ultrasound. And so one lymph node would disqualify anyone from this treatment, and it should by definition make you not want to do it, because it's the patients with lymph nodes that are going to get recurrent disease in the future. Those are the patients that you're going to want to clean it out and give them remnant ablation with radioactive iodine. So unless they got 1 or 2 lymph nodes that have microscopic disease, you don't treat those. But once they have lymph node that you can see on ultrasound, chances are they have a lot more than the one.
What qualifies a nodule as being too big or too risky to treat with any modality?
Okay, so those are good questions, because it always depends on where it is. So some people have nodules right in the front and you can see the whole nodule and you can get to it with a really easy angle. So whereas some people have nodules that are literally behind the esophagus, behind the windpipe, and you can't see the whole nodule. And then the access to get to it would be through the skin to get all the way in the back of the neck. And you don't know where that nerve is. So the last thing you want to be is hoarse from a procedure that affects your voice. And so when you say risky, you think about what risk? Well, the risk could be you losing your voice because you're applying energy too close to it. So you have to be able to prove to yourself, at least as a technician, that you're treating the nodule and you have a safe margin around that nodule, that the heat won't make it to the nerves and essentially damage the nerves. Same thing with the trachea. If the nodule's right on the trachea, you have to find a way to separate the nodule from the trachea. With pulse ablation, we know that this won't damage the nerves, and it won't permanently damage the nerves, and it won't permanently damage the trachea. So it gives you the ability to treat close to those areas. But there are still some that we're not going to treat, and that they're just not going to be ideal candidates for that procedure. And then those are the ones that go down in the chest too far, and some go down the chest and they go underneath everything and you just can't see it. It just disappears on ultrasound.
Yeah, those huge nodules that go down into the chest are unfortunately often too big for radiofrequency or any other thermal treatment. And it would require, so many sessions, it would be prohibitively expensive. And that's why I'm excited that we're having kind of a, what's the word I'm looking for? We're seeing more doctors offering thyroid arterial embolization for those really huge nodules, so that those patients don't have to undergo a very, very extensive surgery for those nodules to be removed from the neck. So if you're watching this episode and you want to know what thyroid arterial embolization is, go check out my playlist on my channel on that topic. Any final thoughts, Dr. Harding, before we wrap up?
It's just been a really exciting process, and I appreciate, your input of this has been tremendous. I get so many patients that have come to my office that have found me through this Facebook site, which has been fantastic, because these patients are well educated and they've been watching it, they're motivated, and they seem to have a good understanding of what's involved. And as a result, they're very easy to treat because they already sort of know what's happening with everything, and they come in, they say, this is what I want. And then you look at them and they're like, yep, you can do all that stuff. And so it's been great in terms of treating these people who find you that way. And so you've done a real service for everybody in this field. So thank you very much on the behalf of NASCET. I mean, we talk about you all the time the crew and NASIT and your contribution to the field.
Wow, thank you so much, Dr. Harding. That means so much to me. It's been a lot of work over the last 6 years supporting this community, but I'm really grateful to know that it's paying off and that it's helping a lot of people. And I'm really happy, especially that you said that the patients are well educated. That's always my goal, is to help patients really to understand what their treatment options are and to make an informed decision.
You've opened up a lot of people's eyes, including the physicians, right? They come because you let us know, where we should be thinking. And so it's been great.
If you've ever been told surgery is your only option, know that this field is evolving. RFA and nsPFA are offering real, effective alternatives for many patients. A huge thanks goes out to Dr. Richard Harding for sharing his insights and experience today. That wraps up today's episode. If you found this valuable, please like, subscribe, and share it with someone who might benefit. You can find links to everything we discussed in the show notes below. Find a physician, discover treatment options, and join our patient community at saveyourthyroid.org. To stay up to date on new episodes, resources, and expert insights, be sure to subscribe to my mailing list at saveyourthyroidwithjen.com. It's the best way to stay connected and informed. There you can also find all podcast episodes and book a 1-hour patient navigation consult for personalized guidance on your next steps. As always, please remember this podcast is for informational purposes only and is not a substitute for professional medical advice. No endorsement is given or implied for any specific product, treatment, or physician mentioned. As always, consult with a qualified healthcare professional for your individual needs. Thanks for listening, and I'll see you next time.